a couple of minutes for everyone to join in. So we'll start. So welcome everyone. Thank you for joining us today. My name is Fotini Teliou, and I work as Research Associate at the Wolfson Center for Young People's Mental Health. It's my pleasure to welcome you to today's lecture, which is part of our public lecture series and the third one for 2023. So the lecture is being recorded and will be posted on the Wolfson Center YouTube page, where you'll also be able to see any other talks in the series that you may have missed. The session is scheduled for an hour. Questions and discussion are encouraged, so please post your questions via the Q&A box, which you'll be able to see at the bottom of your Zoom screen. Our speaker today is Dr. Daniel Pine, a psychiatrist and researcher specializing in child psychiatry and pediatric mental illnesses. He's the chief of the section on Development and Affective Neuroscience at the National Institute of Mental Health. He's currently leading a research group studying neurobiological abnormalities associated with these disorders. Dr. Pine has held significant positions, including chair of the Psychopharmacological Drug Advisory Committee for the FDA and chair of the Child and Adolescent Diagnosis Group for the DSM-5 Task Force. Today's talk will describe what we know about identifying anxiety and providing treatment in children and adolescents. So I hope I didn't make any mistake introducing you, and over to you.
So I want to thank you for that wonderful introduction, and I'll tell you a little bit about how I'm going to spend the next hour to begin things. I'm going to speak for no more than 45 minutes, and then I'm going to open it up for really any questions that you have. I think to facilitate the availability for everybody, I think if you have questions, what I would suggest is that you put them in the chat, and that it's fine if it seems appropriate for the moderator to interrupt me during the talk, but I plan to leave plenty of time to answer questions really about anything at the end of the talk. Just a word or two about my background. As was mentioned, I work for the National Institute of Mental Health. I have a long history of working with children and adolescents. I am a psychiatrist, a physician, so I went to medical school, and I've worked both with adults and children throughout my career. And there have really been two phases of my career, and the talk is going to reflect those phases. One phase was very heavily clinically focused, examining things like the relationship between stress and children's mental health problems in a range of areas, and looking at treatments that are now considered fairly standard. And then the second phase of my career has primarily involved trying to leverage what we know about the brain to improve our understanding and particularly our treatment of pediatric mental health problems. So the talk is very much going to parallel these two phases. I would say that probably about a half an hour or 25 minutes is going to focus on standard understandings, and these will be things that will be very helpful for a lay audience and parents and people who are not particularly expert in aspects of children's mental health. And then in the last 15 minutes or so, I'm going to focus on issues that will be of great interest to the academics and to scientists who are actively engaged in research on pediatric mental illness. And I'm going to try to thread a needle here, both speaking at a level where really anybody will be able to come away from the talk with some novel insights, but also speaking in a way that academics will find useful. I should also mention that I am going to be speaking as an individual here. I'm not representing the United States government, even though a lot of the work that I'm going to describe was supported by the United States government. And there really are not any relevant conflicts that will influence anything that I'm going to describe. So I'm really going to talk about 3 issues. The first 2 issues are, again, fairly standard in terms of what we understand. It's really when we get to the last issue, treatment, that's where I'm going to be emphasizing some of the newer aspects of research. Now, we're in the middle of a pretty broad change that is going on in the way we think about mental illness. For many, many years, we've thought about mental illnesses primarily by focusing only on clinical presentation. So that is how children and parents describe the problems that they're experiencing and how we as clinicians observe these problems. And this has gotten us pretty far. We know a lot about this. But for us to really move forward, what we're going to have to do is we're going to have to use what we know about the brain, and we're going to have to reshuffle these categories. And you see this illustrated here. These are the groupings that we currently have based on clinical classification. What's going to need to happen over time is we're going to need to use data from many different areas: genetics, brain activity, physiology, life experience, and we're going to need to create these new categories. This is going to be something that's going to happen fairly slow. I think we need to be very careful about not overpromising in this area. And I think the place where it's probably going to have an impact most immediately is when we think about novel treatments. And I'll return to this in the last 15 minutes or so of the talk. We can use all of these data to come up with broad categories of mental health problems in children, and using these range of factors, the disorders that we see in children and adolescents can really fall into 3 groups. One group, neurodevelopmental disorders. This includes things like attention deficit hyperactivity disorder, learning disorders, and autism spectrum disorders you see illustrated here. And I'm really not going to be talking about that group of disorders. The psychotic disorders, and the classic disorder here is schizophrenia. We often think of these as adult disorders, but they have strong roots in development. I'm not going to be talking about those disorders. And then emotional disorders. These are the groups of disorders that I'm going to spend the rest of the time describing. And if you're interested in the underlying scientific basis for this grouping, I would refer you to this paper right here that describes how we come up and derive these 3 categories of disorders. Now, when we think about the emotional disorders, we break these down into 2 other large groups. One of them are called the anxiety disorders, and these are conditions that are associated with concerns about harm or concerns about dangers that might impact the well-being of a child. And we typically group these into 3 subcategories. Disorders that are related to obsessive concerns. So these are stereotype, repetitive, recurrent thoughts that often lead to compulsions, which are stereotype thoughts or behaviors that are designed to neutralize these worries. And we think of this as one group of disorders. A second group of disorders is associated with acute stress exposure, where symptoms develop immediately in the aftermath of stress. And we think about these as stress or trauma-related disorders. And we also think of these as distinct, both from how children function when they're healthy, but also from children with other disorders, including OCD. And then the last group of disorders, the disorders that I spend most of my time studying, are what we typically call the anxiety disorders. And this includes a range of conditions that you can see listed on this slide. So that's the first group of disorders that we describe as emotional disorders. The second group are the mood disorders. And the most concerning mood disorder, because it's particularly prevalent and particularly disruptive to children's life, is major depressive disorder, or MDD. And this involves a persistently low mood every day for many days in a row, going on weeks. More than 2 weeks is the threshold we typically set. And this is associated with marked impairment, as well as a range of other symptoms that individuals will describe when they suffer from what we call a major depressive episode. This includes disruptions in sleep and appetite, as well as thoughts about not wanting to live, and other conditions like the anxiety disorders that are strongly related to this, but are not a feature of it. Now, there are many other kinds of mood disorders that are also very disruptive, but are not as prevalent as major depressive disorder in children and adolescents. And we know less about these conditions. And these are the kind of conditions that my colleagues at the Wolfson Center spend a lot of time describing. And there are major questions in all of these areas about emotional problems that both academics and parents face. And some of these questions relate to differences among the disorders, and those are questions that are very important for academics. Among parents, teachers, and other lay populations, the questions are often about the boundary between normal emotional phenomena and things that are a problem. And typically we think about the idea of impairment. So the child who is suffering from an emotional problem that is in need of treatment will be impaired. There will be things that that child cannot do that other children will be able to do. So if it's an anxiety problem, anxiety that is a problem will prevent a child from doing things where they have fear. So if they're afraid of giving a presentation in school, they won't go to school. If they're afraid of humiliating themselves, they won't meet children that they are not familiar with. And the same applies to problems with mood. Typically, children will have transient periods of sadness. The problems that we think about as needing treatment are ones that are prolonged. They go on many days to weeks in a row, and they interfere with a child's ability to do things. Some of the questions that have interested me for a particularly long period of time relates to what happens to children and adolescents who suffer from these kinds of emotional problems. And this is a slide that summarizes a series of studies that I did many, many years ago. And despite the fact that this slide comes from a relatively old study, I highlight it here because this finding has been widely replicated to the point where most scientists who study outcomes in children with mood and anxiety disorders fully understand the findings that I'm going to walk through. However, despite the fact that these findings that I'm going to talk about are widely replicated, many people in the lay public don't fully appreciate some of the nuances of these findings. So this derives from a community-based epidemiologic study on which I worked with two noted epidemiologists in the United States, Patricia Cohn and Judith Brooke, and this tracked longitudinally about 700 children as they passed through childhood and adolescence into their 20s. And this slide breaks down this group of 700 children based on whether or not they suffered from any mood or anxiety disorder, or I'm sorry, if they suffered from an anxiety disorder in adolescence. So that's what's shown here, yes or no. And did they suffer from any emotional problem, any mood or anxiety disorder in adulthood? And there are three bottom lines. Bottom line one, anxiety is extremely common, and it's even more common today than it was at the time of this study. More than a third of these children experience an anxiety disorder at some point in their development. And these are anxiety problems that interfered with that child's functioning. However, children are by and large resilient. Most children who had an anxiety disorder, 191 out of the 253, were healthy as adults. So point number one is anxiety disorders are very common. And point number two is, as a parent or a teacher or a clinician, you can be relatively reassured that most of the problems are going to go away. And I think a lot of people start misunderstanding how significant anxiety is, despite the fact that it is often transient. And it's significant both because children suffer when they have it, but also because when we look at adults, the third thing that we understand is that most of the adults, 62 of the 98 who are affected by an emotional disorder, would have had their problems start in childhood. And this is when we use a relatively high threshold to call something in childhood a problem. When we use a lower threshold, having mild problems with anxiety, we find the overwhelming majority of adults who have problems with mood and anxiety in adulthood, they are afflicted when they are also children. So the last thing to say about this is, I'm showing you data here for the anxiety disorders, but if we would look at any chronic mental health problem of adults, eating disorders, substance use problems, disruptive behavior, personality disorders, we would find the exact same pattern. Problems are very common among children. They're often transient. Children often overcome their problems. However, the minority of children who fail to overcome their problems will mature to account for the majority of adults who have chronic problems. And this is why institutions like the Wolfson Center are so important. They call attention to the need to help our youth in society, because not only will this impact how children function and how they feel, but it also will have an impact on what happens in adulthood. Now, one of the reasons that I shifted the focus in my research towards using neuroscience is that we're not very good at predicting which children will fall into these categories. And the hope is that this will improve with research on neuroscience. All right, let's talk a little bit about stress exposure, and let's talk about two recent sets of findings that have generated a great amount of interest. One is the association between the use of technology and the stress it creates and mental health problems. And there have really been a range of studies that have examined this issue. I'm showing three studies. These are two studies that are illustrated on this slide, both of which use longitudinal data. So subjects are assessed at one wave, at a second wave, and at a third wave. And the studies examine the relations between the amount of time spent using various medias, including social media in this study, and change in problems. And the story is fairly clear from these studies when we look at this slide right here, and when we look at the next slide that I'll show you in a second, that there is an association between the amount of time spent using media and changes in emotional problems, but it is a very weak association and it is not consistent across studies. So if we're looking for a smoking gun or a major explanation for why there have been increases in mood and anxiety problems, use of social media is unlikely to be a major explanation for this fact. If anything, it's a small part of the explanation. Now, the United Kingdom is fortunate to have one of the world's leaders on this issue. Amy Orban is you see listed right here. And these are longitudinal results from one of her studies that again suggests that perhaps there is no longitudinal association beyond the ongoing association, meaning that children who are already having problems might seek out social media and might seek out technology, and that might explain the association every bit as much as any role in worsening related to technology. All right, so what's the bottom line from this first area of work, the work on technology and mental health in children? There probably is a relation here. Maybe there is a relation in longitudinal research, but it's not very strong, and the direction of the association is unclear. That means, is it children's problems that are driving their use of technology and social media? That's probably part of the story here. Or is it social media that's driving children's problems? That's probably not a very big part of the problem. So if we're, again, looking to alleviate problems that children are having, we should probably look other places beyond the use of social media. What if you're a parent? What should you do? I think we think very differently about this if you have a child who is having problems versus you have a child who is doing well. If your child is doing well, I think it makes sense to monitor the amount of time they're spending on social media. But I think you can be relatively reassured that if the amount of time they're using social media is typical of other children, then you can feel pretty reassured that this is not a major risk factor for worsening or causing problems that are not there. On the other hand, we think very differently for children who are having problems, and that's where you need to work with a clinician to figure out how best, or if at all, to limit the use of social media for your child. What about the pandemic? Again, it's a somewhat similar story in that it's highly complicated. We know from years of research that there is a very tight relation between stress exposure and exacerbations in children's mental health. And this is much stronger than the work on technology. Children who are exposed to different kinds and multiple forms of stress have a much higher risk of having their problems either develop if they don't have them, or if they have problems for them to worsen as compared to technology use. We also know that the intersection of psychological stress and physical health problems is particularly difficult for children. And when we think about the pandemic, this creates a lot of problems particularly for children where these things coincide, where they're both having lots of psychosocial stressors and where they are having physical problems that are exacerbating those stressors. Again, because of the complexity of these relationships, we have a very difficult time predicting which individual child is going to suffer. And what we're learning is that it is more the combination of many individual factors interacting than exposure to any one or another stress-related factor. So we should be most worried about children who are having multiple things that are impacting at once. And in the pandemic, this came together in terms of aspects of social isolation. In the United States, the unique demands of distance learning, which was really felt quite heavily by children and families, and also disruption in the family life. Overall, again, it's very hard to predict which individual child is having problems. But by working with primary care providers, at least in the United States, we feel that that's where the impact really can start. This is one of the books that I like most strongly. The version on the right side of the slide is the version that was released in the States, and the version on the left side is available in the United Kingdom. It's by Lucy Folks, a psychologist in the United Kingdom, and it talks about a lot of the issues that I've just described in a straightforward and balanced way. All right, for the last 15 minutes or so, I'm going to talk about therapeutics, and I'm going to fairly quickly talk about what we know about established treatments, and then I'm going to return in the last 10 minutes or so by talking about some of the most exciting work that's happening in neuroscience and how this might impact future treatments. So the first thing to say is that we've talked about the importance of childhood in terms of mental health problems, and there are a lot of things as parents and adults that we can do in terms of taking care of ourselves, recognizing the day-to-day needs of our families, and not getting too caught up in thinking about the future and focusing on how the children in our midst are functioning right now. When we think about children who are having problems, and again, we come back to this idea of impairment, we can be reassured that there are a lot of treatments where the evidence is very clear that they work quite strongly. In the areas of anxiety disorders, this mostly includes cognitive behavioral therapy. This is the treatment that is really established for anxiety disorders as a wonderful therapy. I think it's less established for major depressive disorder. We're going to be talking about medications in a minute. In the United States, opinions are more divided, I think, than in the United Kingdom about the role of medication in child mental health problems. In the area of major depressive disorder, I think many people in the United States view antidepressant medications in general, but selective serotonin reuptake inhibitors, SSRIs, as a first-line treatment. So these are medications like fluoxetine. I know that's not necessarily the case in the United Kingdom. However, for anxiety disorders, most people in the United States, like in the United Kingdom, view cognitive behavioral therapy as the first-line treatment. And as I'll show you, in general, the response in anxiety disorders overall to both cognitive behavioral therapy and medication is stronger than the response in major depressive disorder. And this emphasizes the importance of focusing on cognitive behavioral therapy for the anxiety disorders. So I mentioned that there's particularly strong efficacy for cognitive behavioral therapy, and this likely derives both from general features of the therapy related to providing a listening ear and support, as well as specific components of CBT that involve making a fear hierarchy of things that frighten children, teaching children new techniques to use when they feel afraid, and then working with parents to help children undergo graded exposures to face their fear in a way that the therapist can help partner with parents and children. Now, if you're a parent and you're interested, again, this book is, I find, the best resource. And in all three areas of the anxiety disorders that I described, we really view cognitive behavioral therapy as the first-line treatment, both in the United States as in the United Kingdom. Again, I think that in the United States, there's more thought to think about antidepressant medications compared to the United Kingdom, and that's based on this study that you see illustrated right here. And this compared approximately 500 children and adolescents who were randomly assigned to either placebo alone, cognitive behavioral therapy alone, sertraline alone, or combination therapy alone. And you can see in red that there was some benefit to the combined therapy over either monotherapy. And I wouldn't make too much of a big deal about that. The thing that I would make a big deal about is that the purple line, the sertraline, which is an antidepressant medication line, that it was relatively strongly better than the green line, which is placebo alone. And this is a widely replicated finding in the anxiety disorders, which provides some justification for using antidepressant medications, particularly for children who fail to respond to CBT. So this is a meta-analysis that compares antidepressant medications for use in anxiety disorders and for use in major depressive disorder. So this number right here, 0.71, that shows you the magnitude of the effect size of SSRIs over placebo for anxiety disorders. This is a number that just summarizes the comment that I just made about the strength of the evidence for antidepressants and anxiety disorders. This is very different for major depressive disorder. The evidence of efficacy here is much weaker. If the effect size is 0.71 for anxiety disorders, it's only 0.21 for major depressive disorder. However, the story gets even worse here in that in the only trial that compared placebo monotherapy, CBT monotherapy, and medication monotherapy in the treatment of new onset major depressive disorder, only the medication, but not CBT, was superior to placebo. And that's led many practitioners in the United States to think more positively about using antidepressant medication in children despite this small effect size. There are concerns about the association with thoughts about suicide. This is particularly for individuals who are 25 years and younger. This does lead to caution, particularly for the anxiety disorders. I think less so in major depressive disorder, again, because the data on cognitive behavioral therapy are far inferior for major depressive disorder compared to the anxiety disorders. All right, in the last 10 minutes or so, let's talk a little bit about neuroscience. So we just talked about 2 good treatments. We need better ones. And as I mentioned, this is a place where neuroscience might provide clues about where new treatments might derive. So one approach that people have used is to try to use imaging studies to inform us in terms of how to find new treatments. And these studies look at a data-driven way about the underlying neural correlates that we see related to anxiety disorders. And the good thing about these data-driven approaches, we can generate relatively large samples, such as this study that my group published last year, where there were relatively large samples using this brain imaging technique. Now, the problem with this approach, when we look at the correlates, we see that we can find replicated correlates of anxiety. You see this illustrated here, where a brain connectivity score is derived on the x-axis in these 2 different samples, and a clinical anxiety score is derived on the y-axis. And this is a pretty strong relation, but the problem here is that when we look at the nature of these connections in the brain, they look kind of like a bunch of spaghetti. And that is not very helpful when we start thinking about coming up with interventions that try to target aspects in the brain. So using purely data-driven approaches, they do provide some insights, but not as many insights for the kind of work that my group is doing compared to research that takes a psychological process and tries to deeply drill down to understand aspects of that psychological process. So one psychological process that my group studies is something called inhibitory control. And you see inhibitory control illustrated here. That refers to an individual's ability on a simple cognitive task, when they might have to push a button to the right or the left to indicate the direction with which an arrow is pointing. And when distractor arrows pointing all different directions, might appear behind that arrow. An individual's ability to ignore those distractors and correctly push the button, that's one measure of inhibitory control. So this is a different approach than the spaghetti data-driven approach that I just described. This starts with measuring behavior really well, measures of inhibitory control, and this shows you unpublished data in about 250 kids, where you can see we have these 4 measures of inhibitory control to estimate this latent factor. Now, for inhibitory control, what we find, as do other people, this relates to overall levels of psychopathology. It doesn't relate specifically to things like anxiety or mood disorders. So this has certain advantages in that we do a pretty good job in measuring this well. On the one hand, the model fits are really quite good, but it is complicated when we think of novel treatments that target psychopathology in general. So my group takes other approaches. One approach is we have a whole range of tasks that we use where we expose children to different mildly frightening events. And you can see that we obtain pretty strong data relating response on these kinds of measures to clinical measures. And this paper actually was just released in press last week. So, if you look for Bernstein and Pine, you can find this. But the last thing I'm going to talk about is our focus on attention. My group has really spent much of the last 20 years examining aspects of implicit threat responding, and they're illustrated in this slide, and that refers to instances where a task irrelevant threat captures our attention. And that's illustrated in this slide right here, when this young person is walking through this woods, he's enjoying himself, and he's not looking for snakes, but this snake, which is irrelevant to his task at hand, captures his attention. And there are three ways that we measure attention, using eye tracking, using measures of physiological arousal, or using measures of behavior. And I'm just going to talk about eye tracking measures. And I'm really going to focus on this measure right here. And what happens in this measure is individuals simply sit in front of a screen like this one and just passively view this matrix of faces. And you can see that individuals can divide their time looking at these neutral faces or looking at these angry faces or disgust faces. And we find that individuals with anxiety disorders tend to spend more of their time looking at the negative faces than the neutral faces. This is not a particularly robust finding on the one hand. On the other hand, we do think it relates to treatment. And we think we can use these ideas about attention to come up with novel therapies. And again, this is a paper that was just released online. It'll appear in press in January, but these are the authors, and it describes the range, this full range of novel therapies, and how we use neuroscience to come up with these novel therapies. Now, for the anxiety disorders, which we talked about, are conditions that have a pretty good prognosis. The novel approach that we use combines psychotherapy, cognitive behavioral therapy, with forms of cognitive training. And I referred to this as the pine pizza puzzle. So the idea here is we can think about therapy for children with anxiety disorders as a bit like building a pizza. All children should have certain things, just like all pizzas should have certain ingredients. So they should work with a clinician who establishes a relationship with the patient and the family. And we might think of this as the crust, all right? They should learn aspects of exposure therapy. We might think of this as the sauce. And therapists should help guide individuals about how to overcome problems they're having. Well, maybe these cognitive tasks can give us insights about novel therapies that are a little bit like the pepperoni that we might add to the pizza for kids who are not responding to the treatments that we typically deliver. So the therapy that my colleague Yair Bar-Chaim developed, and that we've done a number of trials using this therapy, it capitalizes on this finding that I described, that children and adults with anxiety disorders tend to focus on these negative faces. What we do in the novel therapy is we have, when children come in and they're enrolling in a cognitive behavioral therapy study, we have them select 100 songs that they want to listen to whenever they come into the clinic. And before they undergo their psychotherapy session, they sit in front of this display and they watch these displays go by them, and they listen to their favorite songs. In children in the placebo condition, they will be getting cognitive behavioral therapy with all the other ingredients, and they'll look at these displays and the music will play continuously. In children who get the pepperoni, so children in the active condition, we link the playing of the music to the viewing of the faces. So in those children, every time their gaze shifts from a neutral face to a negative face, the music stops playing. And children and adults very quickly learn that they should only look at the neutral faces. Otherwise, the music will stop. So again, this is work that's been led by Yair. One clinical trial published about 5 years ago showed that this active form of therapy in the green was better than the control therapy in the orange. And then another study that just came out again last month, adults, these are adults, they're approximately 35 in each group. They were randomized to a weightless control, treatment with SSRI monotherapy, or treatment only with this gaze contingent music reward therapy. And you can see that there was a comparable improvement, both in terms of clinicians' ratings, but in patients' self-ratings of the severity of their anxiety disorder. Now, I actually think we're not ready to start using these kind of therapies yet for everybody who might need them. And there's reasons why I say that we can talk about in the question and answer period. But I think the more important thing to point out is these kinds of treatments and this kind of therapy. And there are some other examples that you can find in this paper, the Sylvester, Luby, and Pine paper. There are other examples that this is really where neuroscience is giving us ideas about new treatment. So with that, I think I'm gonna just bring you back to the needle I tried to thread here in terms of both speaking to parents, teachers, and other lay professionals who might be present, but also speaking to some of the clinicians and other academics who might be in the room. And I'll open it up there to take 10 minutes of questions.
Yeah, thank you for the excellent talk and for sticking to time.
Sure.
Yeah, so I'll start with the order that the questions were asked, if that's okay.
Yeah.
So we start with the broad question, which is why is anxiety more common today?
Yeah, so that's a really good question. There are two big things I would say about this. The first is that it's very, very complicated to examine changes over time in the prevalence of problems. And the reason it's so complicated is the more we learn, the more problems we identify. And for some disorders, it's not clear whether or not they're more common because of that problem. However, for anxiety disorders, it does look like they are increasing and they are more common. But we can't take that for granted for all disorders. So schizophrenia, for example, is probably not increasing overall in prevalence. The second thing to say is that what we're learning is most of these time trends are unlikely to be due to any one factor. They're probably due to complex constellations of things that are interacting. And if there was one factor that we were going to identify, it was the ability for children to handle exposure to stress. Now, notice I was very careful in what I said. It is important that children continue to be exposed to stress. Just like we find extreme stress is bad. We also find that no exposure to stress is also bad. Children need to face the stressors that they encounter, but they need to do it in a way where they can gain mastery. So that's probably the biggest factor in terms of time trends.
Yeah, thank you. So the chart showing the overlap between disorders in children and adults is so interesting. Have you done any work on the impact of labeling these disorders early on? Sometimes
Yeah,
a label. Oh, sorry.
No, thank you very much. That's a wonderful question. So to answer this question, a lot of the work that I do on risk is conducted with developmental psychologists who are not clinicians. I am a clinician, and so it's very hard for me if I identify a problem to not discuss it with a family. I personally, since we know that therapy benefits, I feel like it's unethical if a child has a problem to not label it. However, a lot of my colleagues who are not clinicians and are developmental psychologists raise the issue that labeling a problem has a risk in that it exposes a child to stigma. All right. So to definitively answer the question that you want answered, I'm not sure that we could do a clinical trial that would be ethical because it would involve finding disorders and not telling children. But what we do is we study children with something called behavioral inhibition. That is a risk factor that has an association with disorders, but more than half of children with behavioral inhibition will not go on to have a disorder. And we typically do not inform children about whether or not they have, and families about whether or not they have this temperament because of this concern about stigmatizing behavior that is potentially a normal variation. But what you would need to do, which I do think is ethical, would be to communicate that information to families about their child in a random way and see if that impacts risk.
Yeah, there was a follow-up. So sometimes a labeling is helpful in getting treatment, but I feel it can also reinforce the feeling that sometimes isn't right or child is different in some way. So yeah. So the next question is says, is there any reason why medication is considered the first line of treatment for depression or mood disorders in the USA as opposed to psychological interventions such as CBT?
Yeah, so let me say two things about this. The first thing is I would say that medication is viewed more positively in the United States than it is in Europe in general. People would debate how to think about it as a first line. I think most people think about cognitive behavioral therapy and antidepressants as co-first line treatments, that they're both first line. Some people think CBT should be first line, like in a lot of places in Europe, and other people feel medication should be first line. But I think the middle position, that's my position, they're co-first line. So the second thing to say is that a lot of people question the strength of the efficacy data for cognitive behavioral therapy for major depression. That more critical academics think that European positions are not sufficiently critical about these data, that the magnitude of the benefit that cognitive behavioral therapy has over any control treatment is very small for adolescent depression. On the other hand, the magnitude of the benefit for antidepressants over placebo, which is a very good control, it's not large, but it's typically larger than what one sees between cognitive behavioral therapy and a control psychotherapy. And in the one trial that compared CBT to placebo for major depressive disorder, CBT did not beat placebo, and in fact, the effect size was basically zero. So that's what people in the United States think about. They tend to emphasize that. I'd also say that, and this relates to not just psychopathology, but medications in general. People in the United States take a lot of medications in general for everything. So I think there's probably less focus on all the bad things associated with medicine.
Yeah, thank you. So the next question asks, I wonder why you think CBT and depressants are so much better at treating anxiety compared to depression in young people?
Yeah, that's a great question. I actually think it's more of a measurement issue. When one looks at the data in depression, one of the big problems is that there are pretty big non-specific effects. So both pill placebo and other other non-specific effects have a pretty big effect on depression. And we actually find, we're doing studies with depression, non-specific interventions can have a pretty big effect. And I think we need to spend more time, number one, refining the phenotype. I think there's a lot more heterogeneity in depression than there is in anxiety, and that explains some of the difference. But then number two, focusing on people who fail to respond, people with depression who fail to respond. And that's the kind of thing that we're doing in our studies on depression. We're trying to focus on treatment refractory cases.
Yeah. The next question is, I'm wondering if you think we need better data on the context of social media use, as well as the amount of use. For example, exposure to harmful content might be more problematic than total use.
Yeah, so I'm really not an expert on this. I do read the literature quite closely. And I will say that even when the studies focus on certain kinds of content, it's not particularly convincing on the one hand. On the other hand, it's a pretty contentious issue, and I would recommend having Amy Orben come and give a talk, because she spent a lot more time on this than I have, and I would defer to her.
Yeah.
Oh yeah, good. Yeah, they're great questions here. I'll let you take them.
Where are we? So yeah, have you done any analysis on the types of songs we will use for both groups? So
we really let kids pick their own songs. So yeah, so we haven't really been able to do that.
Yeah, we're a bit out of time, but let's do a couple of more questions.
Right.
So it would be great to hear more about your thoughts about when we might get new treatments into the clinic from neuroscience.
Yeah. Well, I'm hoping to come to the UK this spring, where Cardiff is one of my favorite places to be. So I would love to give a talk all about that. I tend to be, I'm a very glass half full person in my life, but in terms of new treatments, I tend to be a glass half empty type of person. So I think we're at least 5 years away from any major new treatments in kids. But that said, 5 years is not that long. And I do think we're probably going to have more stuff in 5 years.
Yeah. And maybe a final question, I don't know. So can anorexia be considered as a subtype of anxiety as its manifestation?
Yeah, that's a really good question. The short answer is no, it isn't. But in that, the longer answer is in that first slide that I did, where it fits in the emotional disorders is, it's a big question. So, all right. Well, I want to thank
apologies
everybody.
To everyone for not answering your questions. It was very interesting.
And you can give out my email. I'm happy to get an email and answer individual questions. All right.
Yeah, thank you so much.
All right. Bye-bye.